Okay, let's talk about pillars of ethics, right? Like pillars of religion, like pillars of Islam for Muslim doctors. We have pillars of ethics in the exam as well. What are the pillars of ethics? Pillars of ethics, beautiful picture. I will show you and I will share with you from pillars of ethics. Pillars of ethics be shown here. Pillars of medical ethics. Oops. Guys, do you see this? These are pillars of ethics. Autonomy, beneficence, non-maleficence, justice. The doctors who did CASPER before, Dr. Silverman's sisters talk about this all the time. When we were doing CASPER exam, right? When we were practicing CASPER, they talk about this actually pillars of ethics all the time and how to turn the questions in a way that you actually refer to one of these pillars of ethics, because usually the questions are related to these things, right? Professionalism, pillars of ethics, right? Conflict resolution, finding a solution, seeing both sides of the argument or a debate or a discussion. So autonomy, autonomy, autonomy. Autonomy means I do have rights to choose what to do and what not to do for my own health as a human being. Beneficence, beneficence. Do something for the patient which is in their best interests. That's beneficence, right? Beneficence. We try to actually benefit the patient with our treatments. Non-maleficence, which is more important than beneficence, coming before beneficence is non-maleficence. Do not harm. The first rule in medicine. First, do not harm. Then, if you can do something for the patient's good, do it for them. Justice. Justice. We should be just to our patients, right? I cannot pay for a kidney and get priority in the list of the kidney transplantation list, right? There is limited number of the COVID vaccines being distributed in the province or different provinces, right? That's why we should distribute it in a just way, right? There are layers for sure. Some patients, some people might get the priority, right? Like actually first-line responders, right? Like healthcare professionals, the ones that are dealing with the patients, people in the nursing homes, right? Some specific patients with specific medical conditions, right? Right, but there should be a just system to distribute. There is limited number of kidneys available. There are limited budget, limited resources. It should be distributed in a just way to the patients, right? If I am rich or I am poor, I should have the same chance of getting the treatment that I need. And these guys have a roof based on dignity and honesty, right? Dignity of the honesty, dignity of the profession as physicians, and dignity of the patients as human beings, and honesty. We never lie to our patients, never, ever. Mother Teresa, don't forget. In the medical ethics questions, we are Mother Teresa. What would Mother Teresa do in that situation is what we will choose as the best choice. Pillars of medical ethics: autonomy, beneficence, non-maleficence, justice. Okay, I'm sharing it in the chat box, and we'll share it in the WhatsApp group when we make it. Pillars of medical ethics. Oops. I wanted to share this guy, sorry. Right. You can read the article if you need to know more about it as well. Okay, so now going back to our slides, let's talk about, somebody's waiting in the waiting room. Oops, kind of slide. Autonomy, guys. Autonomy. I tried to be super economical with the fonts, with using on the line, with making the basically fonts red, with the colors, because I wanted it to shine and rise in front of your eyes. If you make your handouts colorful, like a rainbow, you cannot distinguish what is important, what is not so important. And you will start panicking when you want to review. The words are chosen like the way that you choose your words in a court, because we are dealing with medical ethics. Autonomy, an adult with the capacity to understand his or her medical problems can refuse any therapy or tests. Adult, capacity, understand, can, any. Keywords. Adult, capacity, understand, therapy or test. In other words, my patient has the capacity, unless proven otherwise. I said it 3 times intentionally, right? I'm a big fan of Sheldon Cooper, but I didn't repeat it 3 times just because I'm a big fan of him, right? Means our patients are competent unless proven otherwise, period. Capacity is what we assess. Competency is what the legal system use, right? Negligence is what we use in medical terminology. Malpractice is what we are being actually sued for. Malpractice, negligence. Medical term, legal term. Competence and capacity are the same. Capacity is what we use and what we assess as physicians. Competence is what being actually decided by the courts. So when I say competence here, I mean capacity. Our patients are competent unless proven otherwise. Means they have capacity unless proven otherwise. The patient has dementia. Which level of MoCA score, Montreal Cognition Assessment Test, or which level of MMSE score, MMSE, Mini Mental Status Examination, will make my patient incompetent or will tell me that my patient does not have capacity? Hello, Dr. India. Everybody. There is no specific score. There is no specific score telling me that my patient is not able to make medical decisions. There is no such a thing. There is no such a thing, okay? It's not based on my MMSE score. It's not based on my MoCA score. It needs assessment of the capacity. That's it. Exactly. They can be competent time to time, judged by mental status. Absolutely. Remember, it's a score. That's the maximum score is 30. The maximum score is 30. It can be actually influenced by my education as well. If I'm a PhD, right, then although my mental status might be a little bit low, but it still can be shown on my score higher than what it is in reality, right? My education, my background, my impact, my MoCA score or my MMSE score. That's a different story. That's a side discussion. But ladies and gentlemen, it's a score maximum 30, right? Maximum 30. If you get above 24, you're normal, right? Above 24 is normal. Above 24 is normal, right? So for my own information, for my own memorization, I remember 10, 15, 20, and 25. What? 10 for me is severe. 15 is moderate. 20 is mild. 25, normal. Haha. 10, 15, 20, 25. MMSE or MoCA score, mini mental status examination, or Montreal Cognition Assessment Test. 10, 15, 20, 25. 10, 15, 20, 25. 10 is severe, 15 is moderate, 20 is mild, 25 is normal, because above 24 is normal, right? Above 24 is normal. 20 to 24 is mild. Different references might use different scores for severe, moderate, mild. But what I'm telling you is quite accurate. Accuracy is the combination of sensitivity and specificity. So what I'm telling you, I try to be as accurate as possible. So 10, 15, 20, 25. 10 is severe. 15, moderate. 20, mild dementia, can be. Or mild cognitive impairment, I would say. It is actually better to be said as that, right? Severe cognitive impairment, moderate cognitive impairment, mild cognitive impairment, and normal cognition. إدراك, cognition, orientation, concentration, memory, right? These are the things that we check in MMSE, right? Autonomy. So there is no MMSE score which makes me incompetent, right? The fact that somebody else is doing my accounting, the fact that somebody else is taking care of my company because I have dementia, doesn't necessarily mean does not necessarily mean that I cannot make medical decisions for myself, period. Medical decision is another layer. It's a higher level of competence, right? Even if my bank accounts are being managed by somebody else, even if my company is being run by somebody else, right? Because I was not able to handle it, right? Still doesn't mean that somebody else can make decisions for me, for my health and for my medical issues, right? I have schizoaffective disorder. I have a schizoaffective disorder, or I have a schizophrenia. Does it necessarily make me incompetent? Does it necessarily make me incompetent making my medical decisions? Absolutely not. Absolutely not. Absolutely not. Absolutely not. We had patients with schizophrenia that got Nobel Prize. Beautiful mind. Russell Crowe. Originally from? Russell Crowe originally is from where? Russell Crowe originally from where? I thought Australia. It's New Zealand. I thought it's Australia, New Zealand. It was last night question in the weakest link. New Zealand. I thought Australian. I was wrong. I was wrong. So I learned something new. So basically, it's beautiful mind, Russell Crowe, beautiful mind, Russell Crowe, right? John Nash, right? John Nash got the Nobel Prize, schizophrenia, a schizophrenic, watch the movie, right? So schizophrenia, still, I might be stable enough to make decisions for myself. I am depressed. Does it necessarily mean that I'm not competent for making decisions? No. I am maniac. Does it necessarily mean I cannot make decisions for myself? No. Still needs assessment. Not necessarily. Not doctors, when you're sending me direct messages, I have to switch to everyone to answer. So there is something here in the chat box to everyone or somebody else, right? Everything is based on competence. Competence. My patient is competent unless proven otherwise. What makes me incompetent? Suicidal, homicidal. Right? Suicidal, homicidal. Active suicide, right? You see, I am cutting my wrists, makes me incompetent. You see, I'm at the balcony, want to jump down the balcony. That makes me incompetent. Active suicide. I am not taking my antihypertensives or I'm not taking my cholesterol pills and eventually it can kill me because of heart attack or stroke. It is not active suicide. Active suicidality will make me incompetent, right? I didn't say all the schizophrenic patients are competent. I didn't say all the manic patients are competent. I said just the fact that the patient has a schizophrenia doesn't necessarily mean that they are not competent. Just the fact that the patient has dementia doesn't necessarily mean that they don't have competence. You need to assess their capacity to understand their situation, right? The understanding of a patient is not necessarily, you're not expecting them to know all the pathophysiology, all the cellular molecular basis of the disease, but something that you expect from their level of understanding. They understand at that level, they have capacity, period. It does not matter if the treatment or test is simple, safe, risk-free. I can say still no to it or yes to it. It does not matter if the person will die without the treatment or tests. It does not matter. It's not active suicide, right? The patient can refuse the treatment or test. Respecting autonomy was one of the first pillars of medical ethics. Respecting autonomy is more important than trying to do the right thing for a patient. Doing the right thing for the patient is what we think is the right thing for the patient. Autonomy of the patient is what they think it's what they want to do. Respecting autonomy is more important than trying to do the right thing for a patient. We'll try to talk to them, but at the end, we will respect their autonomy. Trying to do the right thing for a patient is called beneficence. You're trying to give some benefits to the patient. A 35-year-old mentally intact patient is refusing radiation for stage 1 or stage 2 or stage 3 lymphoma. The patient is saying no to radiation or chemoradiation to the stage 3 non-Hodgkin lymphoma. 35-year-old mentally intact, refusing chemoradiation for stage 3 non-Hodgkin lymphoma. The oncologist told the patient that with treatment, there is 70% chance of remission. And without treatment, there is 80% chance of mortality in 1 year, right? The treatment has a 95% chance of cure, 85% chance of cure, and virtually no adverse effects. And if the patient doesn't actually take any action, the patient might die in 2 years, more than 80%. What would you do? Try to discuss it with him. Honor his or her wishes. Order a psychiatric consultation. Arrange an ethics committee consultation. Get a court order. Ladies, gentlemen, doctors, ethics committee and court order 90% of the time are not the answer to our questions. Why? Because ethics committee means I am not able to handle a simple ethical dilemma. Court order means I want to send everything to the courts, right? So 90% of the time, ethics committee and court order, ethics committee is after I did my best. Court order is my last option when I exhausted all the other options first. Try to discuss it with him. Honor his wishes. Order a psychiatric consultation. Good. I like the split. I like the split. Ladies and gentlemen and doctors, right? It might be a 32-year-old woman doesn't want to take any treatment for that. A little bit digging never hurts. A little bit digging to the situation never hurts. A little bit digging to the situation. For how long are you aware of your diagnosis? Anybody talk to you about the details? How much do you know about your situation, right? Did they tell you about the actually treatment modalities or treatment options that you have? Instead of why, is there any specific reason that you're saying no to treatment? Doc, my mother had breast cancer or lung cancer 20 years ago, and I had to take care of her. I watched her dying, and I watched her suffering, getting these treatments. I don't want to go through the same hell that she went through. Oh, I'm really sorry for what you experienced, right? I try to understand how you felt. I try to see what you went through, right? But let me tell you something. 20 years ago, the medications that they were using are different from the medications that we are using these days. We got smarter with the medications. They are more targeted on the cancer cells, right? They have less side effects and more efficacy, right? And we actually came a long way developing medications for treating the side effects of the chemotherapeutic agents or the medications that we use in chemotherapy, right? So you're educating the patient a little bit about the changes in medications. Doc, even if it is like that, I have 2 kids to take care of, right? And I'm a single mom, right? I cannot get hospitalized. Oh, okay. May I ask how old your kids are? Yes, 8 and 13. Okay. And which grades are they in? How are they doing at school? Are they aware of your diagnosis? Did you talk to them? Did you talk to anybody about your diagnosis, right? You're trying to actually find the social circle and support system of the patient, right? How they can help, how you can involve them. So the patient the patient figures out that she or he is not alone in this journey, right? Having more support around them, right? So it's a grave diagnosis. So basically, we're trying to find some social support for the patient. Okay. And okay, is it possible who is taking care of them when you're not around? You're getting a little bit more, right? So the 13-year-old can take care of the other one or not, how is the relationship, how is your relationship with them, which grades are they in, right? When you're not around, but basically how do they manage themselves, you're trying to dig more. I can tell you that these days we don't hospitalize the patient for a long period of time for getting treatment. They might come into the clinic in the morning, they might actually get back to home in the afternoon, evening, right? It's possible, right? During those hours, if you still need help, we might actually get some babysitting, basically service from the social workers, from the resources that we have in the hospital. I can ask what can be done for you, right? Doc, is there any chance that I need transfusion? Oh, is there any specific reason that you're concerned of transfusion? Yes, I am Jehovah's Witness, and I am not okay with blood transfusion. Jehovah's Witnesses are a specific branch of Christianity that the major medical dilemma that we deal with them, or we have with them, is the fact that they are not okay with any blood transfusion. So we have some Jehovah's Witness doctors as well. If I don't know, in one of the classes we had a Jehovah's Witness doctor on board as well, and he provided us a lot of good information about the options that they have. Right? I'm not sure right now if we have any Jehovah's Witness doctor on board or not. But basically, the major thing that they are not okay with is blood transfusion. So these patients are not okay with blood transfusion. Is there a specific reason that you're concerned with this blood transfusion? Right, basically chemotherapy can suppress your bone marrow, which is responsible for producing the blood cells. There is a chance that your blood counts go low, and there might be a chance that you might need transfusion as well, right? Although we have some other choices as well for the patients who are not okay with blood transfusion. There are some other choices, like basically some medications, the colony stimulating factors injections that we inject subcutaneously to raise the blood counts might be an alternative, right? Might be an alternative. So we are trying to figure out why the patient. Doc, you know what? All these things, I might find a solution for that, but I don't want any hair loss, or I don't want to lose my eyebrows or something like that. Educate them, right? It's a transient thing. Basically, these medications bombard the cells that are dividing fast and quick, like cancer cells. So some cells, like our skin cells, are actually have a high turnover as well, right? So they might get impacted with these medications, but I can tell you that it's a transient thing. You can wear makeup, you can put wigs or something like that during the time that you're getting therapy, right? And it will regrow. There are some stuff like shower caps that ladies use in the shower, not to have their hair wet when they just want to wash their body. They actually put some ice in it, like ice cap or something like that on their head when they're receiving chemotherapy. It can decrease the hair loss. It will not eliminate the whole thing, but it can decrease the amount of hair loss in them. So you're educating the patient, right? I will give you some time. You can think through it. You can talk to the people that you are okay sharing these informations with. I'm always around. I'm always there for you if you need any more consultation, right? And think about it, and we can discuss at the end. If your decision is not taking any medication or not doing any treatment, that's your choice. And as your physician, I have to respect your wishes. So I'm trying to explain to them the options. I'm trying to tell them, right? I'm trying to tell them what options are available. As much as I'm telling you is enough. Should be enough. As much as I'm telling you should be enough. You want more information? There's something called Google, right? Medical issues or medical ethical issues with Jehovah's Witness patients. You can actually always search more. But what I told you is what we must know, right? That is what we must know about them. And the Oscar to this question is always explaining more, right? Even though an adult patient with capacity can refuse anything, This question was from Master the Board, by the way. This question was from Master the Board. Answer: even though an adult patient with capacity can refuse anything, board exams wants us to discuss things first. Even though you may eventually honor the patient's wishes, if an answer says meet, confer, discuss, try to have a gathering, meeting, it's 99% the best first option. The best first option, right? What would I do? Try to discuss with them. And if they're still sticking with their decision, we'll honor their wishes. A and then B. I do not have any reason, any solid evidence that this patient is not competent. So the patient is being considered competent and having capacity. I do not have any solid evidence that this patient has any psychiatric problem. Even if they have any psychiatric problem, doesn't necessarily mean to refer to a psychiatrist for evaluation. We all can do psych evaluation for the patient. We are all trained for doing a psych evaluation of the patient. Is the patient having any psychosis? The patient having any mood problem? The patient having any anxiety problem? The patient are suicidal, homicidal? These are the major things we did it last week. So I'm not going through it again, right, with psych, but we can do a quick psych evaluation for the patient. And I don't have any solid evidences that this patient need any psychiatric consultation. So the Oscar goes to A. Are we good, guys? Are we clear? 5 more minutes and we're going for the first break of the day. Capacity, 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 capacity. Capacity is determined by physicians. Capacity is determined by physicians. Competence is a legal term and is determined by courts and judges. An adult who is alert and not mentally handicapped is deemed to have capacity to understand her own medical procedures and treatments. Dementia does not necessarily take my capacity from me. Schizophrenia does not necessarily take my capacity from me. Depression does not take the capacity from me necessarily. Active suicide does. Active suicide does. Oops. This question, and we'll go for a break. 55-year-old woman presents. I will shut up so you can actually think about it a little bit. Do not get fooled by what is gray, what is white. We have 50 shades of gray in the choices. 55-year-old woman presents to the office with a recurrence of breast cancer. She has refused all treatment for this recurrence. She has received electroconvulsive therapy, ECT, in the past, right? You wanted to choose ECT. Oh, we use ECT. Barely anymore. She has received electroconvulsive therapy in the past for treatment of major depressive disorder. She was well until she heard the news of the breast cancer recurrence 3 months ago. Her family thinks she's refusing cancer treatment because she's depressed. They believe that she should be treated for both depression and cancer Which one of the following is the best next step? Let me check your answers first. Elephant, Bobby, elephant, 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 Bobby, elephant, Bobby, 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 Bobby. Bad, bad, elephant, E, E. You could not delay the treatment. B, 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 B. Oh, we have one C here as well. We have one Charlie here as well. So the doctors are mainly on, you guys, you're 65 people, only 30, 35 of you answered, I guess. So we have elephant, we have Bobby, and we have Charlie. Treat the patient's depression because she's incapable of consenting to cancer treatments. Did you evaluate the patients? Where is your evidence that this patient is depressed? Right? Just the fact that the patient had a previous depression, needed electroconvulsive therapy. She was well until she heard the news of the breast cancer recurrence 3 months ago. Anybody hearing that news will not feel well. But do we have any solid evidence that this patient is depressed right now and the depression is clouding their capacity of their situation, of making decision for their situation? Accept the patient decision not to have cancer treatments. Did you even have a talk with the patient? Just the family is pushing, 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 right? It's the same as the previous question. It's exactly the same as previous question. So the doctors who chose B or C, don't make me disappointed, guys. These are the same person wearing different suits. They're just changing their makeup. So don't get tricked by them. They are the same questions. I told you. The same rules, preset rules. They come in different makeups. If I come tomorrow, shaved or half shaved or trimmed, you don't know me anymore? Let's try tomorrow and see, right? If I have a haircut, you don't know me anymore? If I put a wig or makeup, you don't know me anymore? Let's try. 55-year-old, okay, so accept the patient's decision not to have cancer treatment. What is the difference between the choice B here and the choice B in the previous question? Obtain consent from the patient's substitute decision maker to start cancer treatment. Who told us that this patient is not able to make decision for herself? Who gave you that idea that this patient is not able to make decisions for herself? The patient is competent, 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 unless proven otherwise. Where is your otherwise? Initiate treatment for cancer pending a decision-making capacity assessment. Can you force the patient to get treatment for depression? No, you can't. Can you force the patient to get treatment for the cancer? No, you can't. It's their body, it's their mind. They have authority over that. The same way that you cannot come to my house and take my cigarette from my hand because it's harmful for me, you cannot go to this patient, put a funnel in their mouth and pour SSRI in it to treat their depression. The same way, you cannot come into my place and inject me with some unknown medication. You cannot do the same thing for this patient either. Initiate treatment for cancer pending a decision-making capacity assessment. Delay all treatments until the patient's decision-making capacity can be assessed. You never had a talk with this patient, guys. We never had a talk with this patient. First talk, first see. Especially for treatment of serious diseases like cancer, right? It's not just one shot and over. It's a long-term commitment. It's like a marriage, right? Do you say yes, no? I'm not talking about George Clooney situation. If George Clooney or Charlize Theron proposed to someone, you might say yes right away, right? But for in reality, do you say yes, no right away to a proposal? Right? You assess, right? As soon as your best friend wants to set you up with their brother or sister, you just jump into the conclusion, right? You want to assess first. The same thing here. The same thing here, guys. The same thing here. Are we clear? Change my mind to B. Still B is not correct. The correct answer is elephant. Dr. Nushin, I will kill myself. It's I will kill myself. I will kill myself. Still the patient, you don't know, guys. Look at the choices that you have. Look at the choices that you have. Sometimes you have to go for the best choice. Sometimes you have to go for the least crappy choice, right? It's like a proposal. If you have a lot of proposal, right, you will go for the best, right? If you have not that much, not too many options, you will go with the least crappy one. The same thing in the exam. Look at the options, look at the choices that you have. Among these choices, which one looks the best? Don't be rigid. Which one of these options look to you as the best? Treat the patient's depression because she's incapable of consenting for cancer treatment? How do you know? Accept the patient's decision not to have cancer treatment without having any talk with the patient? Obtain consent from the patient's substitute decision maker? From where? How? Initiate treatment for cancer pending decision-making capacity assessment? Delay all treatments first. Talk to the patient. Talk to the patient. Talk to the patient first. Most probably, this patient has capacity. Most probably, this patient has capacity. It's a different story. The same case came to your emergency department because he took 30 pills of imipramine, 60 pills of amitriptyline after she noticed that her breast cancer came back to her. That's active suicide right now. Save her life. Does it mean that you will take the patient to the OR and remove the actually recurrence of the breast cancer as well? No. Active suicide makes me incompetent. Deal with the active suicide right now. Later on, you will have another talk with the patient. Check about the treatment of cancer. Are we clear? Guys, listen to what I say. Listen to what I say, right? Listen to what I say, right? Listen to what I say. Negative tone? Do not bring your این چیز چیه؟ مال پیانو اینجوری چیز میکنه metronome. Do not bring your metronome for actually checking the tone of the choices. Look at the best choice. 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 Guys, among these choices, elephant is the best choice. You cannot put a funnel in my mouth and pour SSRI into it. You cannot take me to the OR and remove the cancer from me. E, elephant, correct. E, delay all treatments until the patient's decision-making capacity can be assessed. Look at the other choices, guys. Initiate treatment for cancer? How? Based on which evidence? Obtain consent from the patient's decision maker. With what evidence? Accept the patient's decision not to have cancer treatment. You haven't even talked to the patient first. 99% the patient has capacity. 95% the patient has capacity. But still you need to talk to the patient. It's very similar to this question. Try to discuss it with him. Try to discuss it with him in a different way. In a different way. Elephant. Let's go for a break. Let's go for a break.